My chief, Dr. Savapati, says hungry bellies have no ears. So I hope you have ears. So I thank Dhanusha for inviting me. And so I also am happy that Dr. Yogesh Bhai is here. Both of us went along with Vitrag in 2015 to Taiwan together to learn some lymphedema and to see some supramicro. So our journey starts there. So what has brought us back to this topic, which all of us are aware, is more about the knowledge of anatomy and the lymphatic flow. Basically, lymphatic was a very understudied topic because of no animal models like circulatory system in animals. So that is the reason why lymphatic sort of stayed back. But these are the books available right now on Amazon. So you can see the amount of volume of books which have come up on lymphedema. And we are very happy that this textbook, next version, we are writing one of the chapters. So basically, what are lymphatics? We always confuse lymphatics. We used to say it is like a sewage system. Nowadays, we don't use the word sewage, we use the word subway system. So the advantage when you say subway, everybody understands. Basically, we tell them that if all the people who travel in a subway or a metro in a big city, they come to the top, then there will be a traffic jam. So that's easy to understand. And these lymphosome concepts also have been evolved very nicely. And if you see, they all go along with the major veins in the leg. This is from Professor Koshima. So we are dealing with basically in upper limb, going from the chest wall to the axilla, in the lower limb to the groin. The deeper lymphatics go along with the short saphenous vein. So this is what we need to understand. So when we talk about post-cancer, I was just telling madam when we were watching so much of breast, what is happening to all of this? Where are they going, or what is the reason? And once you start operating and seeing them, we keep getting more and more. And it is really astonishing that the amount of numbers we have who have absolutely no clue what to do and where to go. So this is where we started. The reason, as we saw, where they all go is the axilla. Now there are a lot of things blamed to post-operative lymphedema and upper extremity. And the commonest reason we keep blaming the more amount of nodes we take. It is not necessarily the more amount of node, it is exactly where it is going. Many times only sentinel node can cause it. Many times now there are reports which say, if you give chemotherapy alone, we have had patients who have had no breast touched at all, like basically a lymphatic issue, like a non-Hodgkin's lymphoma, and only chemo and immunotherapy given, because they also shrink. The basic idea is vascularized growth factors, which are shrunk by these drugs, and they also can cause upper limb lymphedema. So this is a lady, and this lady also had a axillary vein thrombosis. So many times when you are dealing with lymphedema, we need to really find out what is the exact cause. So she had an axillary vein thrombosis and a lot of neck veins dilated, and our intervention radiologist now has just been operated. He did an angioplasty and sort of dilated, opened the vein, and the vein itself has reduced her lymphedema to some extent. So if you peep into the history where it all started, Corinne Baker, who came to actually one meeting to India, and she was the inspiration for all these what we are talking today. So what her idea was, you are actually removing everything around the axilla, then why not replace that scar tissue with some lymphatic tissue? So that's where the concept of a lymphatic flap or a vascularized lymph node transfer came about. So that is what she did. So she took groin lymph nodes and plugged it there. And at the same time, when that paper came, we had a perforator flap workshop, and Bob Allen, one of the greatest DF flap proponent in the world, and he did this patient. I was assisting him in this case in 2008. And see here, she has a pendulous abdomen. She was having great post-radiation, leakage from here, and a severe lymphedema on the other side. At that time, we were not sort of intending to do what we ended up doing. So basically, we took the DF, and he said, if you take some suprainguinal lymph nodes and then push it into the axilla, that's what we did. So that's the lymphatic, the breast reconstruction, and this groin part went into the axilla, something like Corinne Baker. So now if you see a patient, we actually tell them that doing a breast reconstruction is actually good for you. It's not cosmetic. And now we are able to convince patients who have lymphedema with no breast that breast reconstruction will get you. So it's like a 2-in-1. And you get a third advantage of a nice abdominoplasty. So they are slowly getting convinced. And the nodes which we take, the lower limb lymphatic drains into the vertical channel along the femoral and the saphenous vein. But if you are suprainguinal, what we take along the skip flap. So a lot of proponents now take skip with these nodes, and then they are trying to do that. So if you take the suprainguinal along with the SCI, SIA and SCIA, then you will not get any lower limb lymphedema. So this is a lady, she actually came with another patient and I recognized her face and caught her. She never came for any follow-up. She did not even tell her relatives that she had undergone such a major reconstruction. They all thought there was some breast tumor and she has undergone the treatment. Now moving forward, where are we today? So this is we can combine because we have ICG. At that time we didn't have ICG. So we have marked the ICG both for the recipient and the donor side. This ICG, when it is picked up by the nodes, then that means those nodes we need to avoid. And the ICG which we inject around the umbilicus, those are the nodes which we need to take. So that's what we did. So that's a DF flap. And we also can now combine with the LVA, which we saw beautifully presented before. So we have injected the dye in the hand and we can do an LVA combined along with the DF, the suprainguinal groin nodes and LVA. So this is a lady, the edema started coming down and that's a scar and that's a breast reconstruction. So that's the early results are actually very dramatic. It takes, but still they need to maintain compression stockings. The moment they stop, we will find there is a slight difference. So we encourage them to take that. So moving forward, because groin had some complications of having 2% incidence of lower limb lymphedema, the newer areas which were propagated was supraclavicular. So this is a lady who had a massive lymphedema and so we did a supraclavicular. Nowadays we avoid a supraclavicular because of the anatomical variations and the venous complications. So we prefer to do an omentum if available. So that's the immediate result. This is even at the time of discharge, you will find that the result is dramatic. How does it work? This is $1 million question, still not answered completely. But now these are the various mechanisms told by the Taiwan group, like a pump. But the most significant now is the one is lymphangiogenesis, because it brings viable lymphatic system, and through lymphangiogenesis, what is called as a catchment effect, there is recruitment of more lymphatic tissue and also ingrowth of lymphatic tissue into the transferred nodes, and that's what we do. And ICG system has really created a new, because what we were not seeing before, now we are seeing very nicely, and the pattern we follow. So if you find linear pattern, which is very rare in our cases, if you find a linear pattern, you can do an LVA, but most of the time we see a diffuse or a dermal backflow. So one of the things has been propagated is where you find maximum dermal backflow, if you insert your lymph node in that area, then the outcomes are much better. So that's what we also follow. So this is a pattern you will see. You need to inject in all the 3 territories. So we inject along the medial side, which goes into the superficial system, along the short saphenous side, that's the lateral side, which goes into the deeper system, and along the medial and around the knee. The lateral to the knee goes along the ALT pedicle. So there are a lot of now new reports of taking the ALT and putting into the groin following a post groin dissection, which will also alleviate the lymphatic lymphedema. So this is what we find. So here we find a linear pattern. So we mark it, and once we mark it, we do it. So the new microscope now, both Tivato and Pentero you can do, which was again shown by Dr. Rajendra. So you can see the anastomosis patency. If it is patent, then it is fine. If it is not patent, then you need to find another vein. So this is the result, as I said, immediate dramatic result. This is what we saw in Taiwan in the post-operative ward. Dr. Yogesh Bhai will remember, it was very dramatic. So at the time of discharge, this is how she is at 1 week post-op, and then we start. Now all are not amenable to doing an LVA. So what we do for long standing, see that's a diffuse pattern. So here you have a choice of putting a vascularized lymph node graft. But then if you see her, it is all fat. So this is what I mentioned. If after compression you are not able to reduce that means it's all fat. So fat and lymphedema has an inverse proportional. When you have increased lymphatic blockade, there will be lipodystrophy, and vice versa. When you have lipodystrophy and increased fat and BMI, there will be lymphatic blockade. So it goes hand in hand. So here it is mainly fat. So what we have done, we do liposuction. Earlier we were doing only liposuction, world was doing only liposuction. Then the new concept came, because it is not like the liposuction we do for cosmetic procedure where the skin tone is good. Here if you do liposuction, it will keep oozing. So here what we do at the end of liposuction, see how much is the redundant skin and excise the skin in the same sitting. So actually you need really 3 to 4 surgeons to do it, because it's a long procedure. So one team does the liposuction and then we step in. So my colleague Dr. Raja he does the liposuction part and I do the debulking part. So that saves a lot of time. So this is how she looks. She's very happy. She wants a second sitting of liposuction for the. So if you see the arm has reduced now, the forearm is still having a lot of fat. So we will do it in the second sitting and the other side. Now coming to the lower extremity. So lower extremity is actually more in number, but not visible because, as I said, they all wear in India they wear saris, so it is not visible. Whereas in Japan, where we went, we were not even able to know which side is affected because it was very early picked up by ICG. And the 4 criteria which have been found reported to have maximum incidence is the number of nodes you harvest, the BMI of the patient, and the post-operative radiation. So it also depends on the criteria. So number of nodes removed, the paralytic nodes more than 20, radiotherapy, but significantly associated with lower extremity lymphedema. So they present like this. This is really dramatic. If you imagine this lady was walking around without even, she has shown to many people, but all had no answer. So she came to us. So here we apply the principles of plastic surgery, is just basically needs. So first we need to create a multidisciplinary team. So our team comprises of pressure garment, footwear, compression therapy, and certified. They all got trained in Amrita. Actually, Amrita conducts a lymph the therapy course, so CDT course. So we can, if you want, you can send them. MRI is a good tool for finding out whether it's fat. You see, this is all fat. So MRI can find out difference between fat and fluid. So it's a normal leg, whereas this. So this, then we continue with compression. So we don't operate immediately. The same lady, she first we undergo compression, and then we do a 4-layer bandaging. This is there. It's all there online now, and we have it on our. So if you see the dramatic results, this is pre-compression, this is post-compression. So many times if the skin quality is good, they can continue with just with compressive stocking, and then we do debulking. So this is, and then after compression, they cannot wear a normal footwear. So straight away we give footwear. So footwear is available in our OPD for all the patients. Now coming to the three basic things we do. If it is very massive like this patient could not walk. He had a CA penis and irradiated, and he was having great difficulty even in standing. So we resorted in amputation. Even amputation and fashioning a stump is very difficult. So we amputated. Actually, there is a nice picture I didn't put here. The weight of the limb was 47 kgs, is same to the nurse who was assisting me in this surgery. So there's a nice picture. She's standing along with that. So he first time started walking. Before that, he was just barely able to walk. He's still on catheter because of the penile amputation part. So that's the Autobach processes, and he's quite happy. Now coming to what we do in lower extremity. See, these are all not amenable to any microvascular procedure. So here we just do debulking. So first we do CDT, the skin becomes soft and supple, then we enter and do a massive debulking. So that's a debulking done. Many times they come with a lot of ulcers. The ulcers also start healing once you do good compression and debulking. And this is a stocking we need to provide. They need to go right up to the umbilicus. So you should not just give a below elbow, below knee stocking. They should have right up to the abdomen, because otherwise they will get compression here. So this is what we do. And this is a young male with a post-testicular carcinoma. That's how he presented to us. This is post-CDT. So you see the difference between the pre and post-CDT. And that's a role of liposuction. So we found that there's a lot of fat here. So we do liposuction and simultaneously debulking. So this post-liposuction and post-debulking. Now coming to that same lady here. So this is the ideal CDT apparatus we need to have. It's not only having a chamber going up to the knee. They should actually cover the whole body. So this they undergo 20 minutes morning and evening, 2 cycles. So this is the same now the lady how we went about it. So this is after that immediately we put a 4-layer bandaging. 4-layer cannot cover the toes, so we have a small customized for the toes itself. You see the difference in 1 week. So we tell them 1 week till we reach this stage, no procedure to be done. That's the difference you find in just 1 week of, and then we go ahead with liposuction and debulking. So liposuction is done for all the areas where there is a lot of loose fat. Here we need to do debulking. So that's a liposuction. We really sucked a lot, and then this is a post-op, and this is a post-excision. Now she undergoes, she's quite happy. If you see the other side, it has also improved significantly with the compression stockings. So that's a customized garment given to her. Post-CA ovary, another lady, it's quite similar. Here you see it's mainly lipodystrophy. If the feet are not involved, so that means there is actually not so much lymphedema. So his feet is the main differentiating factor. a single sitting of liposuction and massive debulking, you get a good result like this. We try to preserve, so it's called a perforator preserving radical resection. We don't disturb both the veins, short saphenous and the great saphenous. We stay behind it and we preserve all the perforators also. Finally, there are indications for doing vascular lymph node transfer in the lower extremity. So this is a lady again with CS cervix, and that's a supraclavicular node which we have harvested. It's based on the transversocervical artery which we saw the flap in the morning. So transversocervical artery and vein. We also take the external jugular as an extra donor. It's a nice scar, but the only thing is the anatomy is not very consistent. Same sitting we do an LVA because we found a linear pattern here, and that's a result. It's a nearly around 4 months follow-up. But then at this stage we need to put compression. They all come back now for further reduction, and now you can do a liposuction. So doing a liposuction post vascular lymph node flap is not a contraindication. We move away from the line where we have put. So this is the equipment we need. We saw that. So we have both Pentero and Tivato. In both you can see ICG intraoperatively, and the sutures we use is 10-0 and 11-0, and of course the instrumentation. Gamma probe is very useful if you are doing a reverse mapping. So now you are ready to do manage the cases of, I think all of you will see lots more. When I asked Peter Nelligan, who wrote the Nelligan textbook, what is the future of plastic surgery, I think we discussed all three today. He said number 1 is transplantation, number 2 is computer aided planning, and number 3 is going to be lymphedema. So I think the take home message, these are the gurus. If you want to spend time, all of them have large volume of cases. Hassan is now a fellowship program for lymphedema in Korea, and this is from Taiwan, and Koshima is sort of not yet retired, 80 plus. So I thank you all, and I welcome you to our workshop which we conduct every year. This year we will also have some LVS and lymph node flaps in the workshop. Thank you.